Hello and welcome to Level 5, Unit 501, the Principles Underpinning Health and Social Care. And we're looking now at week 2, where we're going to focus on task 2, which is the areas of legislation and codes of practice. So the criteria in task 2, it's a 650 word section. And it's about evaluating the impact of government policy, legislation, codes of practice and standards. Okay, so what they want to hear from you is from your research and from your reading and stuff that you do in your private time and the experience you're getting from your work placements, is that some sort of evaluation of how these things actually impact your day-to-day job. Okay, so 2.1 is focusing on a piece of government legislation in health and social care and its influence on practice. So it wants you to evaluate what influence that piece of legislation has on practice. 2.2 is again another evaluation. So remember this, it's not a description, it's not an explanation, it's you evaluating. Remember strengths and weaknesses, good points, bad points, balancing it up, coming to some sort of conclusion. Okay. And that part is how codes of practice influence professional practice. Now you've got 650 words here. And you can break it up as you want, but I want you to write it in task format. Okay, now you're at a level 5 level, and I'm going to keep repeating this through this unit. You need to not just be writing to individual criteria and giving me like the number of the criteria and a little paragraph. I want you to write the whole task. You can use the task header like task 2, task 1, but I don't want it sort of written just as a paragraph that relates to a criteria. I will find your criteria answers, okay? And as I said, I'm going to repeat that in each one of this week's this unit, each week of this unit, just to sort of embed it, because the first one you did was the research project, was quite a large project, and I'm hoping that you didn't do it that way then. But for the rest of the level 5s, I just want you to address the tasks. Don't break it down into criteria, please. I will find the criteria. If you've met it, you've met it. If you've missed it, you've missed it. Okay, so that's up to me to find. That's sort of what I'm trained to do. Okay, so with government legislation, there's quite a lot of government legislation. So what I've done is I've focused on the one sort of big, most recent piece of government legislation in the UK, well, in England, really. There are some little tweaks in the other 2 countries of the UK, although it's pretty much the same sort of legislation, but they have a few little tweaks. So rather than confusing you, I'm just gonna stay with the English legislation. You can choose any piece of legislation. I'm going to go into the Health and Care Act in a bit more detail because it's the biggest piece of legislation that happened in England. But I'll sort of reflect at the end that you can pick another one as long as you do a decent evaluation. So the example that I'm going to sort of think through today is the Health and Care Act. As you can see, 2022, fairly recent piece of legislation, had a huge piece of legislation as well. It repealed the Health and Care Act of 2014, 2016, which was just slightly tweaked. This has got a lot more changes in it. You can find the full act on UK gov.uk if you want to actually find it. It's very, very long. So I'm just trying to give you an overview. So it came into force on the 1st of July, and the main aim of the Act is to transform how NHS England is organised and how it can go forward improving health and care services. One of the issues of the previous health and care legislation for a good, I don't know, 15 years, has they've failed to tackle inequalities in healthcare provision, healthcare services. Um, so the aim of this one is to really work at tackling inequalities. Now, whether or not it pulls it off is, I can't tell you. It is early days, as you can see. Although it came into first on the 1st of July, obviously changes have got to be made locally in different places, and they take time to bed in. So bear in mind that for a couple of years it's going to be a little bit chaotic. And considering that we're still suffering from chaos and catch up because of the pandemic of 2 years, um, I can sort of give you a bit of a clue of how some of the health service providers feel about making loads of big changes in the way they do things. Have a guess, okay? So it's not so easy. It's also a mechanism to amend other legislation and introduce a range of changes. Some changes about the role of CQC, adult social care, a price cap on the care costs. That's for, because we don't use insurance systems here. We have some things are free at point of entry, some things are means tested. Some sort of change in training requirements around learning disabilities and autism. So the slides I'm focusing, as I said, it's a huge bill, and you may lose the will to live if you try to read it all. But I'm just picking up the key changes that I think, will affect providers like yourself, practitioners. One of the most important things is the integrated care systems that have been established, and they are based geographically at different parts of the country, bringing sort of localities together. And they include providers and commissioners of the NHS services and the local authorities, because there used to be quite a split. The NHS provided healthcare, local authorities provided social care, and sometimes when one of your clients had a foot in one camp and the other, there was a bit of a mismatch, people not being able to work together. So the integrated care systems have been planned for quite a long time, and it takes a lot to try and get these things together. And the aim is to coordinate and commission health and social care services, under one umbrella, really. Not dividing it up as, are they sick or are they not, but what are their needs. I was a commissioner quite a few years ago now, and I was a sort of joint commissioner, which was the beginning of this integrated care service. And that goes back to, I was in that role in about 2005. And some local authorities and had started this joint commissioning role, but again, we still had quite a space away from the practitioners. So as a commissioner, I could only ask people to do things, could tell them to do things. That was a problem. So the integrated care systems consisted of two bodies: integrated care boards and integrated care partnerships. A lot of commissioning used to be what was known as a clinical commissioning group. That's been abolished, and these functions have been taken over by the integrated care boards. And that includes NHS continuing healthcare, NHS funded nursing care, joint packages of care. But also it includes other health services like dentistry, GPs, community nurses, equipment services. And the good thing that's really different about this was, what I see as a positive thing, is that the CCGs were very much doctor led, usually led by a group of GPs. So they were much more active about commissioning things that they felt were useful for themselves. And sometimes when, only a certain amount of people needed it, they tended to sort of bypass it a little bit. um, not really thinking about all these sort of other things like equipment services and what the community nurses could do and what the local dentists and pharmacists were capable of doing. They sort of had a bit of a silo brain because GPs are very much medics and didn't really think about, sometimes is there another way we could do things? They also very much led the board as well. So some of these sort of smaller areas didn't get representation on the board and weren't able to speak up and say, hang on a minute, we could do that better. So the whole idea is that these groups will be part of the board. So primary care networks, place-based partnerships, health and wellbeing boards, they all become part of it. The ICPs, the partnerships, have a role to ensure that services are of a high level. So that's a commissioning role. Okay. So somebody who, like me, who in one of my jobs, I was a commissioner, I would now be part of the integrated care partnerships. And to do that, it's to make sure that this joint work across social care and health is actually done by the same group of people. In that sense, everyone's got a bit of stake in it. But also in those partnerships, and as I said, some of those things were started a long time ago when I was doing it. These partnerships, but they weren't part of legislation then, but they are now. So there's an expectation, and some areas did them better than others. Some areas didn't do them at all. Some areas started them, and some areas just sort of pretended to do it. But now legislation, it's all got to be reported on and shown and demonstrated. And it means that service users and some of their carers can be involved and are intended to be involved in these partnerships. Another role that's slightly changing, those of you who've done sort of level 3s and 4s with me, we've talked often about the role of CQC. We know it's got a regulatory role. We know it's important for their inspection angle, making sure that things meet standards, usually care services. But they also cover GPs, dentistry, and hospitals. They are sort of expanding their role yet again from April of this year. They will review, assess, and report on local authority adult social care. Now, they've never done that before. It's quite a new role for them. They have reported on local authority care homes, which some of you work in, but they've never actually reported on the whole processes of adult social care, so like the commissioning role and that will be interesting because they'll be working with people that they're not used to. It really depends on how good their understanding is on adult social care, because local authorities are covered by all sorts of legislation and restrictions and regulations on how money's managed and spent, as you can imagine. And their view is to see how the local authority do their role. So I can see some clashes there. I can see, depending on personalities and also the experience of the CQC role, some people may be good at it, some people maybe not. There may be some problems. Bear that in mind as part of your evaluation. So they're actually developing a methodology. I haven't seen it yet, so it'd be interesting to see what sort of guidelines they give them. But as of the moment I'm creating this, I haven't seen it. Integrated care systems, NHS England makes sure all committees and systems are accountable, and CQC's role is to be part of that accountability. They will review the integrated care systems, and they will review part of their role would be to see how well the partners are integrating and working. Because as I said to you before, some of us had integrated care systems, but some of them were a bit half-hearted. Some of them had some people who were very active and worked well together. then some people chose not to work that well together. So, you could go from one town to another and it could be very, very different. So the idea of CQC is obviously they'll be working to a standard. They haven't really got it yet, but they will be working to a standard to consider how well partners are integrating. And I guess that'll be reported back up to government. So that's a new one. The duty to cooperate is also something that's fairly new. There's always been guidance around cooperating and working well together, but now it's become a duty. It's set out in legislation. Again, we're still waiting for that real specific guidance. There should be a guidance paper on how this should look in practice. So as people know exactly what to expect. Haven't seen that yet either as well, but no doubt it will come along sometime. We've had quite a lot of I suppose the best way I could put it is turmoil in the last 6 months in the UK government. There's been lots of changes of personnel, and prime ministers, and various other jobs. So it's the last year has been a bit topsy-turvy. So hopefully some of this guidance will come out in time and get signed off. Information sharing and data gathering. This is also highlighted in the Act. Again, lots of work has been going on for many years about information sharing. And again, different authorities, some areas have done quite a good job on it. And some areas are not so good. The area where I live is about half and half. It's done some good jobs in some areas. We've got some very good electronic records now. I use an app to speak to my GP and to book appointments and to do all that sort of thing. There's been quite a lot of a good IT work going there. But how I do know that there is still some issues passing information between different departments. Going to and fro the health service, there's a lot of complicated passwords and access keys that are required, which is quite frustrating for people who work in care homes like yourself, having to wait to get information from the health, and then only certain people having the access key to open it up and that. So there's quite a lot of work for NHS Digital to do, really. And also, they're trying to standardize how everything's collected, because again, one of the things that was very interesting years ago was when we did set down the road of integrated care records, lots of different local authorities bought different systems. No one gave them a guideline as to what system to buy, which is great. But if someone went from one authority to another, because people do actually move, it was very difficult to transfer things because the systems didn't talk to each other and things like that. So that was a real problem. So there's a bit of work. There's still ongoing work to do with NHS Digital. And another piece of work is to NHS carries an awful lot of data and produces an awful lot of reports. Adult social care services, again, depending on the local authority, will produce their own data, and the two don't mix because they're not talkable systems. So there's another requirement for NHS Digital to get some data from adult social care, which they do have, but they just never ask them for it. That's my experience. To find out what's actually happening in adult social care, the sort of people, the sort of needs, and that. So they eventually can produce a whole needs assessment of the local population, and that it's analysed and understood, and it's not just healthcare needs. I am a little surprised they've given that job to NHS Digital, because the NHS Digital have always been very slow about how they do things. And I personally think the local authorities could probably do it a bit better. So they do have all the information. But I guess they weren't. I don't know. Maybe nobody asked them. I don't know. But I think, because the NHS get very tied up about security of information and that, because stuff's very personal. So it is in adult social care, but somehow they tend to sort of find ways, to make it easier. Social care practice issues, you'd be quite interested in this, I hope. There used to be a delayed discharge requirement, so that people couldn't leave hospital without a needs assessment having taken place, or they couldn't actually physically leave the hospital, even though if they were quite well, especially if they were elderly or had disabilities. You had to do the needs assessment before they could go home, and this caused a lot of bed blocking, people not being able to go home. Until a social worker was available to come and do the full needs assessment, which is actually quite a large document. It's fairly holistic, as you can imagine. And it was a real problem, really, because what happened is sometimes people moved without any assessment because there was a lot of pressure, and there were some financial penalties as well. So if social services didn't get them out, then they would get fined, or if the NHS didn't shift them quickly, they would get fined. And all this money was just, I don't know where it was going. But it was money that would be much better used, patient fronting work, and instead of sort of, it's a big stick. They needed to resolve some of the staffing issues, which meant that there wasn't a social worker free to do the assessment because they take the whole afternoon, so they have to be sort of worked in amongst their other work. So they really needed to review that, really. So they've repealed that. So it means that the full assessment can take place after discharge. Now, that doesn't stop. If they think someone needs to move into a care home, as you know, as you work in care homes yourself, you'll do your own assessment anyway, and you won't wait for the big detailed one that comes, because you do what's sort of important for you. And as long as the care home is able to get in, and they can get their staff up to do a sort of fairly decent assessment and decide whether they can offer a service to the person, that usually can get them moved quicker. And then the full needs assessment, the more, the all bells and whistles one could be done at a later date. So that's what's happening now. So you can have to think about how that would make it a bit easier for you. But it probably won't change. Again, one of my experiences was we would very often get a phone call at about 4:30 on a Friday afternoon saying we need a social worker to come and do a needs assessment because we need to move Mrs. Jones out today. And you sort of think, yeah, okay, Friday afternoon. Now, first of all, I can't find my social worker because she's might be, in another part of the country doing a review, and I don't have a spare one to, Friday afternoon. It's very hard to ring up care homes and say, have you got beds? Because, things go a bit quiet on a Friday, and it's quite hard to move somebody in on a Friday afternoon. Those of you, again, who work in care homes, it's quite difficult, especially if the manager goes off at 5 o'clock, blah, blah, blah. So whether it was resolve that problem, I don't know. So have that in mind as well as a practical problem. Caps on care costs. There is a contribution. It is means tested. People with the means, people without the means will be paid for to a point. People with means, there was never a cap. They kept, it all got a bit hazy, and they kept changing their mind. And they have decided now the maximum cap of 86,000 will be paid. So in other words, if someone sells their house, they'd only have to spend over their lifetime up to 86,000. And that means that the remains of the money for their property will go to their families when they die, no doubt, or unless they want to spend it and go on a world cruise with it. But really, it used to be no limit to it. So all of people's savings. Now, a lot of people have a discussion about the principle of this. The general feeling is if you've got money and you've sold your house because you need long-term care until you die, and you've got 400,000 in the bank. Well, why shouldn't you spend it on your care? Some might say. But there was a lot of people who objected this. It's basically they had nothing to leave their families. It's very personal, and it's very much what your politics are, I think, as to whether you agree with it or not. You might want to sort of discuss that, but I wouldn't get too deeply into that because, quite honestly, it's something that all sorts of treaties have been written upon, and if you sat down and had a discussion with your classmates, you would find that all of you might have a different view on that. So you can, if you just want to mention it, it's fine. Remember, you've only got 650 words to talk about here, and you're only half of it is this criteria. Regulations are expected to be in place in some local authorities by this year. Again, I think that's pretty much happened. Other issues: mental health services, always been the sort of Cinderella service, as we call it. They need to be prioritised because a lot of health money would go into physical health, and there wasn't any ring fence money for mental health. Now they haven't ring fenced it, so it's not a definite, but they have told them they have to be prioritised. So you think about how you feel about that. Whether is it a bit of a cop out, or is it are they showing sort of that they're thinking willingly? But ICBs will have to evidence their spending. Now, I don't know, when CQC do the review, how much is enough spending? I don't know. I mean, it would depend very much, as inner city boroughs that are very deprived will have higher mental health needs than rural councils with little chocolate box villages with wealthy people in them, I think you'll find. So there's no point just saying you have to spend this much per town because that doesn't really work. And again, if you reflect on the places that you've lived in, you know that some areas are more deprived than others. And with deprived areas tend to become more mental health demands. So they've been told, but they do have to evidence their spend. So they can't sort of show a big fat zero when it comes to mental health. So that's a good thing. Adult social care providers payment. Now, the Secretary of State for Health was allowed to give financial assistance to some health and care providers, particularly health and social care, but they were only allowed to give it, apart from the statutory services like the NHS, they're only allowed to give money to charities, like non-profit making bodies, which is very difficult for some of the private providers that actually worked on quite small margins, as you can imagine. They weren't a big wealthy company. They were just a small care home. Some of you may work in homes like that, which sort of worked on on the breadline, really. The act has been extended so that she is able to give financial assistance in certain cases to some private sector providers where it's needed. Now, again, I believe that that'll be at their discretion, but the fact is they're now legally able to do it. They might be able to help some services out rather than them going bust or not being able to provide. So they might be able to give special grants for, I don't know, social activities or things like that, which means they'll provide a better service. 2 new criminal offences, which is first one for quite a long time, really. They relate to virginity testing and hymenoplasty, that's reconstruction, the hymen. And this is because there's been issues with some cultural groups where young women may have lost their virginity one way or another, either by accident or if doing a sporting game at school, these things happen. And then them not being able to get married or people not taking them on as a bride, and then people having to doing reconstructions, which is very painful, very unpleasant, and often doesn't work very well. So they've been outlawed, they've been made illegal with or without consent, with or without the young woman's consent. You're not allowed to do it now. And not just the people carrying it out, but people who are helping to do that. Um, they would be in breach of the law, and that would be a criminal offence. And also, actually testing someone's virginity before marriage is actually going to be a criminal offence now. So if somebody takes someone off to their doctor and asks them to do it, the doctor would be committing a criminal offence. So a lot of them obviously will be refusing to do that because it causes a lot of problems, and it's sort of very much against the cultural norms of the country that we live in. Um, Female genital mutilation, such as cutting, which some of you probably know about, that is already illegal. So that they've just added this really to a new criminal offence, and it's part of the government's violence against women strategy, and you can go to prison 5 years or a very serious fine. The last thing really is mandatory learning disability and autism training. It's been a big gap in a lot of people's knowledge, and a lot more people are dealing, especially in care homes, are dealing with people with autism and various types of learning disability or neurodiversity. And the Act's actually been amended to actually require that all providers ensure that their staff receive training. There's been a lot of mandatory training, but uh, LD and autism has never really been on a mandatory, although I know a lot of providers that do provide it and have done for quite a long time. So, but if you're working again, if you're working in England and you're working in a care home and they haven't provided it, it's something that can be asked for, and saying it's actually legislation now that you must be part of the mandatory training. And I guess it would be something that CQC, when they come and do their reviews, would be looking for to see it's been done. And I think that would be very good because there's quite a lot of people who work in care who don't have a lot of experience dealing with people with autism or neurodiversity, and it'd be great for them to at least have some basic training about it, and so they can approach people the best way. Because otherwise, it can cause a lot of upset for both staff and the service user. So remember now, I've given you that one. You can also look at other pieces of legislation. I'd like you to do some private study from your resource folder. Um, I've given you some documents that criticise or pick up issues from the Health and Care Act. So that Patients for NHS, that will be in your resource folder. And the BMA, that's the British Medical Association, the doctors basically, they're briefing about the Health and Care Act and the areas where they're not happy as well. I've also given you a couple of blog links where people feel that there's lots of areas that haven't been addressed. So that will help you with your evaluation as well. Obviously, if you don't wish to do that, you can actually go on to look at some other legislation, such as mental capacity. And I've put some resources for that because that's a 2005 Act. Safeguarding Vulnerable Groups, 2006, Human Rights Act 2000, Equalities Act 2010. So you can do that. If you don't want to use what I've already given you, you can do your own piece of research. But remember, whatever you use, make sure you focus on the evaluation of it. I don't want you to spend half your task words on telling me about it. Okay? I know I'm repeating myself, but sometimes I have to. So you can give me a couple of lines, giving me an overview, picking up some points, but really you can pick up the points in the evaluation. So assume that I do know about it, and you can say some of the issues around the Mental Capacity Act is, some of the concerns about some of the changes are, and then you can, that way you'll show me what some of the changes are anyway. I need to know that you understand the acts, so I need to get enough from what you've written to say you understand it, but the evaluation, your criticism of it, strengths and weaknesses and that, good points, bad points, that will show me that you do understand it. Okay, we're going to go on to look at the second part now, of the criteria, which is about codes of practice. So don't forget, you're going to run this together. The task answer is a paragraph of writing, or a few paragraphs of writing, 650 words. And I want you to run it together. So you need to move from one topic to the other. And that's going to show me some of your writing skills a little bit more. Okay. So we're going to look at codes of practice now. So let's think about the purpose of a code of practice. You can use this as part of your evaluation. Why do we have a code of practice? It's to set out conduct that's expected of all the workers. It's to inform service users and the public about the standards they can expect from workers. It forms part of the wider legislation, sets practice standards, and it can be part of employers' policy so that they know what sort of training they want to provide, what sort of skills they need to work on. And looking at the codes of practice, it can help them write their procedures as well, because it makes you think about what you need to include. So it has quite a good purpose. It makes sure that you as a worker are responsible for making sure that your conduct does not fall below the standard. So that bit's on you, okay? And that you don't take any action that's against your code of conduct. So it does give you a framework to function in. The council expects social care workers to meet this code, and they may take action. Those of you who are working in a registered capacity, they can deregister you if they feel that you're not doing it properly. They usually give people a chance to improve, but if they don't, they don't. And employers obviously need to take this on board, because they can use this code of conduct again as a framework to think about how they manage their staff. So thinking about yourself as a supervisor, this code of conduct gives you a framework to manage with, and also helps you make decisions. Is somebody a good worker or not? Well, do they meet the code of conduct? Do they meet the standards of practice that's required? So that helps you as a supervisor. How will the code be used? Most people will be registered. The register will be a public record. If somebody meets the code, they will remain registered. And if there is misconduct, they will look at it against the code and help to inform their decisions about how to go forward. What will the code mean for you as a worker or as a supervisor or a team leader? It will give you the criteria, as I said, to guide your practice, and it has a clarity about what standards of conduct you're expected to meet. You can use the code to do your own reflection, look at areas where you might improve, prepare for your supervision, think about your future training, think about your personal development plan, think about your objectives, think about what you want to do for the next couple of years. And also for members of the public or a service user, it also helps them understand how that worker should be behaving towards you, what they should be doing with you, and what approach they should be taking. And that will help them sort of be able to raise issues, complaints, or concerns, because again, they've got a framework to work with as well. And it helps employers to know how people should be supported. What should they be able to do? what do you have to do as an employer to help them get there? Okay, especially if someone's new, especially if someone's inexperienced, it's a developmental process. So let's look at them now. There are 6 points to the code of conduct. Sorry, the codes of practice. The first one is that you as a worker must protect the rights and promote the interests of your service users and carers. And this is about treating people as an individual, and it's a bit about promoting their individual views. So remember, a person-centered approach. We know about person-centered approaches. Supporting service users' rights to control their lives and make decisions and be consulted about what they want to do. And that's about giving people informed choice. Respecting and maintaining the dignity and privacy. We know about that. We know about knocking on doors when we go in. We know about asking when is it convenient to come to do something. We know about them saying, no, actually, I'd rather like a lady to do that piece of work with me, or no, I'd rather like a gentleman to do that piece of work with me. And also promoting equal opportunities to make sure all your carers get access to services so that, you know, they can, just because someone's in a wheelchair, it doesn't mean they can't go out to the shops with other people. How do you promote that? How do you make it happen? You've done quite a lot of work on equalities, so thinking about that. And also about respecting diversity, thinking about people's different cultures and values and being aware of it. Not everybody can know about every culture in the world, but the fact is it's whether you sort of make an effort to try to find out. Okay. So number 2, you have to strive to establish and maintain the trust and confidence of service users. And this is about being honest and trustworthy yourself, really, as a worker or a manager, communicating in an appropriate, open, accurate way. So, you know, being honest, being straightforward, not lying to people, not distracting them, not confusing them, respecting their confidential information, knowing your confidentiality policy, knowing how to operate in it. You know, there are times when you do have to divulge information, and you need to be able to tell people that so they can't expect you not to. But, you know, being discreet about people's written information, putting things away, not leaving them out for anybody to read, being reliable and dependable, being there when you say you will, not coming late when someone's waiting to do a piece of work with a service user and you turn up half an hour late and, you know, service user's been waiting. Honouring work commitments. So if you've promised to take a service user out shopping tomorrow, and if you can't do it and you've got a good reason, explain it to them, but try to honour it where you can, you know, make sure that your manager knows that you've made commitments to people, that they don't pull you off, send you off to do, you know, work in a different department or something. Declaring issues that might create conflicts of interest. Sometimes you're not sure what is a conflict of interest, so I would say always ask. You know, if your partner works in a supplier that the care home is buying things from, and you think there could be some problems there, make sure people know about it, or don't get involved in the actual sort of exchanges or financial exchanges, things like that. Like I said, if you're really unsure, I would say always talk to somebody more senior. Adhering to policies and procedures about accepting gifts and money. There's a lot of issues about this, and some service users, you know, and families and carers really get upset when people turn down gifts. And nowadays, quite a lot of care homes have got a sort of thing about gifts more than a certain amount of money, like £20 or something like that. Or they have it sort of particularly like, you know, because a lot of service users like to bring chocolates if someone's coming and going, or if it's a birthday or something. You know, if they really, you know, think well of a key worker, they might want to bring them some chocolates on their birthday or something. And I know certainly in the care homes I've worked in, we've had a little bit of leeway in that, which we always checked out with CQC. as CQC sort of like chocolates, flowers, gifts under £5 or things like that. But you know, some places would just rather have nothing at all. Then there's not a problem as long as you follow whatever the policy of the organisation is. Okay, Code of Practice 3. You must promote the independence of service users while protect them as far as possible from danger or harm. This is really looking at your risk assessments, isn't it? Having established processes and procedures, challenging difficult behaviour or challenging behaviour, and knowing how to deal with challenging behaviour. Making sure the service users can be as independent as possible within their own personal limits, and trying to find ways, if there's something they really want to do, trying to make it happen for them. Bringing to the attention of your employer any operational difficulties. So if there's any procedures that they have that stops you delivering care safely, or you know, maybe they've got some machinery that needs renewing, that doesn't work properly, don't just use it, but you really need to log up that you're unhappy about using it because it's unsafe. Complying with health and safety policies, all of them. And you know, if your manager tells you to do something that breaches health and safety, I would try and get it documented, because health and safety will always win out over your manager. I can tell you that now. Certainly it does in the UK. They are very, very powerful people. So think about it. Helping service users and carers to make complaints and making sure those complaints get taken seriously. Passing it on to the right people, speaking up for them when maybe they can't speak for themselves. And recognizing your own power and using it responsibly. And that's probably the most important one, really. You have an uneven power relationship with your service user, whatever you think, no matter how good and kind you are, and how much you care for them, your power relationship is uneven. So just be aware of that when you're asking people to do things. You know, they may do something just to keep you quiet, or they don't want any negative comeback about that. So be very conscious of your situation. Number 4, you must respect the rights of service users while seeking to ensure their behaviour does not harm themselves or others. Again, this is back to risk assessment, making sure you have policies and procedures, making sure you carry them out, you making sure you do risk assessments where you need to. But also take steps to minimise risks, not eradicate risks. Generally, it's impossible to eradicate all risks. There'll always be one that gets around you. And the other is that it might be something that the service user wants to do and is willing to take a certain amount of risk. If you're really unsure about that, then make a team decision, but involve the service user and any of their advocates. Okay. Remember that service users do have that right to take risks. And even if it's sometimes a bad decision, it might not necessarily be an unsafe decision. It might just be not the best decision. And you can't get them to not do it just because you think their decision's wrong. If you're unsure about this, you may need some training in that area. Please do it. Flag it up. But again, don't just do these decisions on your own. If you're having to put a risk assessment together and you're really not sure about what the service user wants to do, sit down and maybe have a talk with someone more senior to say that she wants to do this. I think she might hurt herself. On the other hand, she doesn't care, because she feels that the outcome would be worth it, even if they run a risk of her falling over in the road or something. And you might be able to make it happen in a way that you can reduce the risk. Remember, it's about minimizing risks. You cannot remove risks. The only way by doing that is locking someone in their room and never letting them leave, and that's not what we want to do. Most important thing about all risk assessment work that you've done and risk assessment planning is to make sure other people know about it. There's not much point if you've created a wonderful risk assessment for you and the service user, and then you get struck down with flu and you can't do it, and that one of your colleagues has to take them out, and then they find out that they don't know anything about the risk assessment. The service user gets upset because they're saying no, we can't do that. Yeah, but I've got a plan in place. Oh well, so make sure that communication's good, things are well documented, so if you're not there, things will be passed on properly. 5, you must uphold public trust and confidence in social care services. Yes, you might be in a private organisation. Yes, you don't necessarily work for the health service or the local authority, but that doesn't mean to say that you don't want people to have confidence in your service, especially the people who live locally, who might be considering moving into your care home, maybe in 10 years' time, 5 years' time, 2 years' time, you don't know. So, in particular, you must not abuse, neglect, or harm service users. I think there's another reason not to do that apart from just public trust. It's not very nice for the service users. So, um, you know, whatever. Exploit service users, carers, or colleagues in any way. You must not abuse the trust of service users, abuse their personal information, give access to people who shouldn't have access to either your service user or their information. You should not form inappropriate personal relationships. Now, I know we've discussed this in, I think at least at level 3, I'm pretty sure we did. So you can go back and look at some of this work then, because this unit really does build on stuff that we've done over the last 2 courses. You should never discriminate unlawfully or unjustifiably. I think unjustifiably comes first, but do remember there is actually a legal issue around discrimination. So, and that could become even worse for you than just discriminating because it's not very nice. Don't condone other people's discrimination just because it wasn't you who did it. If you saw something that happened and you know it was incorrect, you do need to act on it. You do need to be responsible and do something about it. Don't put yourself and other people at an unnecessary risk unless it's something that's part of a risk assessment that's been very well calculated and worked out. That might be a little bit risky, but might be something that all involved have decided is worth doing. Don't behave in a way outside work which would call into question your suitability. Now, some people think that once they're away from work, they can do anything they like. I think you'll find that employers nowadays don't see it that way. And I can certainly tell you that I have seen and I have had that experience when I worked in the local authority of people being sacked from their jobs because of things they posted on their Facebook pages. Bearing in mind it was an actual abusive tirade against the head of adult social care, which seemed a bit stupid to me. But the fact is, it's considered bringing the organisation into disrepute, and most organisations will have that as a sackable offence. So they very rarely have to, discuss it. And the fact is that once you put something out on Facebook, it's out there sort of forever. It's not just Facebook, Instagram, TikTok. So just be a bit careful. You do something when maybe you're not in your, full control of your faculties, and you post it around the world for everyone to see. And you might find that it might pop up for your employer, who might think, no, I don't think I want people like that working for us. So if it brings them into disrepute, or if they feel it can, you don't tend to have a lot of grounds to stand on. It's quite a hard one to fight, really, especially if you're drunk and being a bit of an idiot, or if you're being abusive. Well, you just won't win the argument. So just bear that in mind. 6, leaning out of that, you must be accountable for the quality of your work and take responsibility for maintaining and improving your knowledge and skills. No one's saying you have to pay for all of your training, There is a certain amount of training you would expect your employer to provide, but if you don't ask for it sometimes, then you could be criticised as well. You need to meet relevant standards of practice. We know that. We've talked about that. You need to follow policies and procedures. You need to maintain clear and accurate records. And again, this is all something we did in level 3, so you need to inform your employer about any personal difficulties that might affect your ability to do your job competently and safely. If something's happening to your eyesight and you can't see what you're doing and you're waiting to get some new glasses and you've had a real decline over the last year, you just need to tell your employer, say, look, I don't think I should give that medication because I can't actually see the numbers. I'm just waiting for my glasses to be updated. Then people will respect that. If you don't and you poison someone or give them an overdose, they won't respect that. It's sort of fair enough, really. Working openly and cooperatively with colleagues, treating them with respect. This is just general group work, being a team member, being a good and decent team member. Recognizing that you are responsible for work that you have delegated to others. So, especially those of you who are moving into supervisory roles or team leader roles, just remember, just because you've delegated something to someone, you are still responsible for it because you are the supervisor. You are the person who delegated it. When you delegated it, you made a decision that they are skilled enough and know enough to carry out that piece of work. If you are wrong, it is on you. Now, I know you used to say, well, they should tell me as well. Yes, they should. You both have responsibilities, but you will not, you will both be held responsible as well. People do need to speak up, but you need to know your staff too. Recognising and respecting the roles and expertise of workers from other agencies. That's working in partnership, really. You will have people in and out of your care home, as no doubt you do, from the GPs, dentistry, pharmacy, social workers, physiotherapists, even all sorts. You need to maintain a nice, good, professional relationship with them. And you need to recognise and respect them, that they know what they're talking about. So don't disparage the physio because maybe they don't know the person as well. They still know how to be a physio. They're trained, they're qualified, so give them a bit of respect. And they will give you respect back. So it goes both ways. Undertake relevant training to maintain and improve your knowledge. So don't refuse training when it's given to you. You need to have a very good reason why. And that might not be good enough. If it's some of the mandatory training that you need to do your job, then if you keep refusing to go on the course, if they're sending you on a course that you can't get to, that you don't have any transport and it's miles away, and it's got to be reasonable, and then you can raise issues about that. But if it's not, don't you need to go really and take it. The other issue, which most people will be concerned about, is when they're not being offered the training that they need to have to do certain parts of their job. And if that is an issue, and if you've raised it, you need to document it. You need to raise it formally in supervision. Say, like, I've asked for this, it's 6 months and I haven't got the training. I don't feel safe enough to do that without the training. And then if something goes wrong, then at least you've had it documented that you felt you weren't trained enough. If you feel that you're doing something that you really do feel unsafe doing, then you should refuse to do it on good grounds that you haven't been trained enough. You can't use that as an excuse for everything, because in time people will say, well, you've got to learn as well. But if you're using a piece of equipment that no one's shown you how to use, then you are on pretty good grounds to say, I don't want to use this, or I'll use it with someone, or a bit of supervision. Can you watch me do it to make sure I don't cause a problem? If you think you're going to endanger someone with doing it, then you need to take responsibility too, though. It's a two-way street. Okay, so those are the codes of practice. And hopefully in some of my conversation, I might have identified where some of the issues could be, but it's up to you to do a little bit more research and think of an evaluation as to why the codes of practice are valuable. If you go back to the beginning, the first couple of code of practice slides, I do say what is the purpose of them, and how do they affect you, what they do for you, and what will they do for your service users. So you should be able to, with this information, have enough to do a little evaluation. Are they useful? Are they not? Do they achieve what they want? Could they be better in different ways? What are the weak points? Does it give room for your manager to cop out somewhere? As well? If that's what you think, then say so. But you need to evidence it for me. Now, try to get some citations in there. If you can find a little bit of research to back up what you're saying. Of course, you're at level 5 now. This is undergraduate level. So everything should be backed up with some sort of research. Okay. And then using your proper citations and referencing. You can pull some case studies out if you can find some case studies, but bear in mind you've got 650 words for both of these two approaches, really. Okay, so that's all there is. I will see you for week 3, where we will be looking at person-centered care and some issues about social isolation. So we're looking at some of the theories behind it. Person-centered care and social isolation work. Okay, I'll see you then. Goodbye.